Well, I want to welcome everybody. Most of you know who I am. I'm Deborah Balaga, and I am president of NAMI Marin. And I have the most amazing honor and privilege of welcoming you to this workshop. You're in for a treat. For those of you who have participated in our prior sessions, welcome back. You will know how engaging and informative Dr. Turkington is. And for those of you who are new, welcome to the experience. What I wanted to say, in addition to welcome, is that the partnership with Dr. Turkington has been ongoing for about 5 years. We have done 3 programs together. And the last one, which we recorded, is one of the most popular resources for NAMI Marin. They're posted on our website. They are the most visited matters on our website. Our helpline refers to them all the time because the information is so helpful to families. Now, you may wonder how we managed to form a partnership with Dr. Turkington, who is thousands of miles away. In a bit, I'll answer the mystery. But before I do that, most of you know that evidence-based cognitive behavioral therapy is the gold standard therapy for serious mental illness, sometimes in conjunction with medication. What you may not know is that this program is unique. Around the world, as leading practitioners focus on CBT, there are many training programs, but they are typically for mental health professionals. What Dr. Turkington and NAMI Marin have done together is to design a program for families and caregivers using CBT principles, but modified in a way that will be usable by those of us who are family members. With that, I would like to introduce and thank 3 key people who have made this program possible. The first is the William Girl Swigert Family Fund. This family fund is our longest standing donor and supporter. They've been with us from before I got involved with NAMI 6 or 7 years ago. They were our initial supporter when we were all volunteer, and they were our own financial supporter. And they have been with us for the journey. And as a result of their generous donation, we can offer this program for free to all of you who are participating. So we thank them profoundly from the bottom of our hearts. The second person I want to acknowledge and thank is Dr. Robert Reiser. He's the unsung hero here. He's a board member. He's a Marin County psychologist, one of the few treating serious mental illness. He's an instructor at UCSF School of Psychiatry and also an instructor of the leading institute for CBT in the country. And the reason I want to thank Dr. Reiser is the answer to the mystery of how we formed a partnership 5 years ago with Dr. Turkington sitting in Newcastle, UK, thousands of miles away, is the idea for this program came from Dr. Reiser. And Dr. Reiser and Dr. Turkington have a professional relationship which has grown over time. Dr. Reiser has donated thousands of hours of pro bono time to make these programs work. So I want to thank Dr. Reiser for having the idea, sticking with it, and helping us get these programs to you. The third person I want to thank is Dr. Turkington. It's just been a pleasure and a delight working with him the last 5 years. If I were to talk about his credentials, we'd be here all morning. Most of you who have signed up, no doubt, know that he is one of the leading practitioners, clinicians, researchers in this field. He gives talks all around the world. He is much in demand. He's highly published, many, many articles, many books. He is the expert. And so I want to thank Dr. Turkington for being a partner with us. It really is extraordinary and a wonderful opportunity. With that, I need to turn to the boring things, and I'll try to do these quickly. In the packet you got yesterday and on the screen are just some guidelines to make the program go efficiently. On the screen, Doug, can we have the, actually go back to the overview of the program? Yeah, okay. All of you have seen this in the materials we've been sending out. This is the first in a series of 6, and the topic is principles of recovery. We've spent some time talking about how to do this most efficiently to encourage the most participant involvement as possible. So the basic overview of the structure of what we're going to do for this program is the first part is a videotape that Dr. Turkington has specially prepared for NAMI Marin. This is not a canned presentation. This is special for us and the needs of this community. And it's going to be in 2 parts. The first part will be a video, but there will be portions along the way where there'll be time for 1 or 2 questions. And we ask you for that to focus your questions on the particular subject that he has been talking about. The second half of the program will be open question and answer on any topics, any of the ones that he's been addressing during the course of the program. In a minute, I will tell you how to participate with questions. To make that happen, let's turn to the guidelines. Dr. Turkington, if you would. I know that many of you have other demands on your time, but the way this program is structured is that each session builds on the next. So if you can possibly participate for all, we'd really appreciate it and think it would be most beneficial for you. If you can't attend, elect not to proceed for whatever reason, just let us know because we do have a waiting list. Okay, so the question procedure is probably the most important thing for you right now. Is the way that you can submit questions is by clicking on the chat feature at the bottom of your screen. Most of you are pretty familiar with Zoom at this point. And you'll be given an option as to whether your chat will go to the whole group or privately to Dr. Reiser. What will happen then is we'd ask you to send them to Dr. Reiser. He will then put together the questions and avoid repetition and select some. We can't get to everybody, I'm sure, given the limits of time. And then he will get the questions to Dr. Turkington and he will answer them live. We would ask again that during the video portion, when we break for questions, that you focus on the topic that has just been discussed. Okay, number 3, if we could change the slide. Okay, so the question format, there's really only one request that we make of you, which is that try to make your questions generally applicable to everybody without specific family details. And there are a couple of reasons for that. One is that Dr. Turkington can't provide medical advice, and there's just not enough information or enough time to do it. And also, we really want to make sure that the Q&A is relevant to everybody watching. So just try to avoid family details if you can, and frame the question as broadly and generally as you can. I also want to mention confidentiality, because these are obviously sensitive topics. And the first hour presentation will be recorded, including the intermittent questions when we take short breaks. The Q&A session in the second half will not be recorded. So similar to the last piece of guidance is please don't include any confidential information in your questions if you can avoid it, because we are going to be recording. Zoom etiquette, you probably all know this. Please make sure your microphone is muted. Your camera can remain on if you choose, unless it's going to be distracting, like if you're in your car or whatever. You can choose how you view the participants. If you use speaker view, you're going to be focusing on whoever is talking at the time. Gallery view will give you more people. If you have any technical problems at all, you can contact Miriam Salem. She's one of our very important staff members here at NAMI Marin. Send her a private chat and she'll try to help. The next slide, please. Actually, there's one more with 0.7. Well,
That's all I've got, Deborah.
Okay, well, I can just talk it through. The last point I was going to make is actually the most important of all. And that is that we're going to ask people to please sign a survey, fill out a survey at the end of the program. We've done this before. The last program, we got such incredible guidance and feedback from people. It really helped us dramatically in improving what we do and being responsive. So please, at the conclusion, please complete a 2-minute survey at the end. There will be one of the last slides will have a link that you can go click on to fill out the survey, or you can just, there will also be a link in the chat room. Feedback is so important for all of our programs, but also throughout the 6 sessions that we're doing. If people have comments about things they'd like to see done differently or that didn't quite resonate, let us know so we can adjust as we go forward. So thank you for your participation. Welcome. And with that, I will turn it over to the celebrated Dr. Turkington.
Thank you very much, Deborah. It's a great honor to be here this morning and speak to family members about CBT-informed caring. And my first subject is the principles of recovery. And I must say this is a fresh presentation because although I've been working with families and helping move towards recovery for many years now, I have never distilled my thoughts into one presentation. So this is quite fresh. So I'll be very interested to hear what family members think about the content. So please put things into the chat. Questions and ideas will be very welcome. So these are my top principles of recovery, and we're going to go through all of these today. And I hope that you will find some nuggets in here which are interesting and possibly even useful for you within your family. The first principle is, what about recognition? How does it occur that someone who is trapped in psychosis comes to think that there could be a way out of this, that there could be a new direction? What is that recovery trigger for that person? Now, it must be said that almost everybody who recovers from a severe mental disorder can remember their recovery trigger. So this is an interesting point. I'll give you an example. I'm going to be talking about recovery stories as we go through this morning. A lady called Frida was in a psychiatric ward for 20 years. She was heavily medicated. She spent her time listening to her voices, which she believed to be extremely dangerous. Her self-care was poor. And one day the senior nurse was showing a brand new nurse, a young nurse, round the ward and introducing the patients. And the senior nurse came to this lady, Frida, and said to the young nurse, "This is Frida. She has been in the ward for 20 years. She is our longest staying resident." And Frida was, wow, that's a bit of a shock. 20, has it been 20 years? And it had. And the young nurse was about the same age as Frida was when she had first developed psychosis. And the young nurse said to her, "I'll come back and speak to you later when I've got a minute." And Frida, for the first time, told her all about her voices, all of her fears, the things that had happened to her in the past. And that was her recovery trigger. She remembered from that moment on, she started to work her way out of the hospital. Now, Frida does international workshops on recovery. She has moved from being paralyzed by psychosis to giving something back, to a kind of altruistic perspective of helping others. So, can we recognize recovery triggers? And what can we do to initiate a recovery trigger? So we're going to talk about that. We need to talk a bit about medicine. And I must say, I don't receive any funding from any pharmaceutical company in any way. But some people recover with medicine, and we're going to talk a bit about that. I'm a CBT expert, but I think that there are a range of psychological supports and therapies which can facilitate recovery. It's just that CBT is the best researched of them, and hopefully the most available. What can happen within families to trigger and maintain a recovery trajectory? It seems clear that most people do begin their recovery at home. It's not always clear when that's going to happen, but it normally does begin in the home environment. You need to be with other people if you have a severe mental disorder to begin to work your way out of it. What about group therapies? Group therapies are popular, and recovery can happen in group settings. People with psychosis are extremely aware of the social milieu which surrounds them. And any change in the social milieu can make things worse, or can go the other way and trigger a surprising recovery trajectory. So social approaches are very important. I mentioned altruism, and when people who are stuck in psychosis start to talk about their psychosis and start to help other people, they've gone a long way down the recovery pathway. The last one, and perhaps one of the most interesting, is the fact that many people who have suffered from a severe mental disorder tell me that once they've come through it, they're actually a better person. They've been enriched by going through that experience. So I'm going to talk about positive aspects of psychosis. These are my principles of recovery, which can work in a sequence or can work out of sequence, depending on the person. So, a recovery trigger. Let's have a think, first of all, about what remission is and what recovery is. Now, remission means that your symptoms are all gone and you've returned to your previous occupational and relationship trajectory. You've had your psychosis and you've put it behind you and you're back into life from where you were before. Now, that's obviously the ideal situation if that can happen. And remission can certainly happen in psychotic depression and in bipolar disorder sometimes, but the medical textbooks tell us it's rare in the schizophrenia spectrum. Now, everything that's in the psychiatric textbooks is currently being challenged. The recovery model first developed out of the Hearing Voices network, where it was established that lots of people hear voices and they get on about their daily life and they have integrated their voice hearing into their personality. I was interviewing a man the other day and going through a psychiatric interview. I said to him, "And do you ever hear voices or hallucinations?" And he said to me, "Well, I've got a spirit guide, and the spirit guide speaks to me at various times through the day, but that's really not any of your business," which I thought was fantastic. So there's lots of voice hearing out there. There's lots of psychotic symptoms, and people don't need to be stigmatized about them. So the recovery movement is very much about overcoming stigma and helping people to see that these kind of symptoms can be a part of your life, but you can be very efficient in your life with them there, and you can control them. So the recovery movement was about acceptance that you've had a major disorder, becoming hopeful and optimistic about the future. Now, insight we're coming to in the next lecture. It's a very interesting subject. But the thing to say for today is that insight fluctuates and improves over time. So there may come a time when recovery becomes more possible, even if it's not possible today. Setting targets or goals, improving self-confidence, because we better believe a major mental disorder knocks the self-esteem out of you. And then trying to achieve personal meaning. The lady who went from 20 years in a psychiatric ward to doing recovery workshops believes she has discovered meaning in her life through the psychosis. And that is very important. So the psychiatric textbooks do talk about remission, but they say that it's rare in the schizophrenia spectrum. The psychiatric textbooks don't say much about recovery, which is interesting. In the medical literature, it's left kind of black and white. And it might be argued it's too pessimistic a view that we should be expecting recovery. Now, recovery isn't like this phoenix arising out of the flames. And I usually get concerned if I see a very quick recovery. I can tell you about a client of mine who we'll call Tom. It's not his real name, but and Tom became very psychotic in his early 20s. And I saw him at home, I saw his family, and I started to work therapeutically with him. And he accepted medication and he responded within about 3 weeks. And by a month, he was back to his old self. He was in remission. The phoenix had arisen from the flames of psychosis. And he was back. His friend said he's back. He's his old self. And it was a wonderful thing to see. And I said, look, this medicine that's got you better and this therapy that you're just starting, we need to keep these going now. We cannot stop the medicine. The nice guideline is if you recover, you need 2 years of medicine and you need to have your therapy so we can work out why the psychosis happened and help you deal with any symptoms that might come back. And he said, Doc, I absolutely get that. That's fine. I'll take my medicine and I'll see you again in a week. I said, great. Next week, my appointment was cancelled and he stopped his medicine. 2 weeks later, his mother phoned me to say, he's not making sense. We can't understand a word he's saying. A lot of it seems delusional. He's really deteriorated again. So the phoenix arose from the flames and went straight back into them again. So recovery needs to be a slower process than that. Work needs to be done with the psychotic symptoms in terms of where they've come from and what they're about, both emotionally and in terms of working out other explanations. The medicine needs to be taken for long enough for that therapy to be done. So recovery is a bit slower. It's a road that we travel on. And it's crucial that the person who is entering recovery is working with somebody that they feel able to disclose to and talk to and open up with as they begin to fight their way out of the depths of the psychosis. And I always say this is usually somebody at home. It can be like that young nurse, somebody in a ward. It's a great opportunity there for that to happen. It could be a therapist, and often is. It could be a psychiatrist, but very often we don't see our clients often enough to facilitate that recovery. Now, recovery is strongly influenced by social and cultural factors, and it seems clear that your culture is in many ways protective against psychosis and can be an important part of recovery. People struggling with schizophrenia and severe bipolar will very often say there's only one thing worse than the symptoms, and that's the stigma of having this particular poorly understood disorder within Western society. So that the stigma can be a massive block to recovery. Is medicine available for them? That's an important question. Even if the person will take it, is it available? Is therapy available, both individual and group? We'll speak about befriending later, because befriending is a powerful vehicle for recovery. And are there training options, voluntary placements? As you begin to recover, you need to put your big toe into the water of life again. And that might mean doing a bit of voluntary work or doing some online training. So are these things available? Now, if we are going to recover from psychosis and have a recovery trigger, one of the best ways to work out what that trigger might be is to work out, where has this disorder come from? And I'm really just talking about the schizophrenia spectrum disorders here. There's been a very recent publication showing progress on the genetics of schizophrenia. We used to think that the genes were between 1 and 200 small genes, which all made a contribution. They've narrowed it down now to 10 genes that contribute to the vulnerability of schizophrenia. So it looks like some people can have quite a genetic cause. And if that is right, we want to know that, because that can help us understand the right medicine for that genotype and the correct trajectory into recovery. But there's, as you can see in this diagram, there's lots of ways into a schizophrenia spectrum disorder. Migration from another country is massive. If you think about asylum seekers coming into the UK or coming across the border into the southern states of the United States, migration is an uprooting of the person from what they know into a different social system. It's a powerful cause of psychosis. Bereavement and failure to grieve is a powerful cause. So I've had patients who have said to me, are you telling me that my relative's death is the reason that I'm paranoid now? And they'd never made that link, the fact that they'd never grieved at all over the death. And I said, well, let's think about that. The timing of it fits in very, very closely. And this person that you're talking about was actually the closest person to you. So does it seem likely that that could have been the cause? Now, for this person I'm thinking about, that grieving process was the beginning of the recovery trigger. So where has the psychosis come from? Can we identify it? Certain types of epilepsy powerfully cause psychotic symptoms. That being the case, we need to discover about that and do a brainwave test and treat the epilepsy, and then the psychosis improves. About half of everyone in the schizophrenia spectrum has an underlying trauma history, and people don't make the link. It's perhaps surprising. The voices are being abusive towards them. They're saying all kinds of negative things to them, and they've got a history of abuse. So you're telling me that these voices are something to do with the fact that I was emotionally abused and then sexually assaulted? Would that fit? Here, the recovery trigger is to realize that trauma was indeed probably a big chunk of the cause, and making that link is like a eureka moment. Wow, maybe there's something we can do about this. Maybe I don't need to be stuck any longer. So, recognition that you can change. There's a number of ways of discovering that recovery trigger. Now, this goes way back to the Bloiler and Kraepelin argument. Bloiler said schizophrenia is just one thing, and that's that. It doesn't do very well, and you don't really get much better. Kraepelin said the schizophrenias are a group of different psychoses. They have different causes and different recovery trajectories. Now, myself and David Kingdon followed the lead of a Bloiler in terms of, of Kraepelin, in terms of saying that there are different disorders here with different types of recovery. We spoke about genetics there. There are some types of schizophrenia, but we think it's only 20% where you're genetically predisposed. And that being the case, the medicine and avoidance of excessive stress is very important. We now have a new scan available, which at the time of the first episode of a psychosis shows you whether or not there is excess dopamine in the limbic system in the brain, and that's the area which is normally overactive in schizophrenia psychosis. So within the next 5 to 10 years, any young person getting a first episode of a psychosis will have their genetics done, and they'll have the scan done, and then we will stand on firm ground as to which particular medicine they need for recovery, or whether they need to go down a therapeutic route towards recovery. The drug-induced psychoses, people that have their psychosis triggered by, say, LSD, ecstasy, amphetamine, whatever it might be, they usually recover quite well from it, and they very often go straight back out and take more drugs and become psychotic again. So this is an increasing manifestation of psychosis in our society. And recovery from drug-induced psychosis needs, yes, medicine, but it also needs a lot of therapy going on. We need family therapy to support the family who are usually traumatized by what's happening to their loved one, and they need individual therapy around their psychosis, the underpinnings of the psychosis, and ways to cope with life without the medicines. So drug-induced psychoses need particular treatments for recovery. There are some very organic types of psychosis. We mentioned epilepsy as a cause, and catatonia as a cause of autoimmune type psychosis. They need different types of treatment altogether. And then we see about half that really need to be seen an expert therapist. And we know that CBT can work with the trauma and with the voices and the delusions and successfully resolve them in many cases. Now, it's also been shown that EMDR, eye movement desensitizing reprocessing therapy, which is an effective treatment for PTSD, works for people with severe mental illness and psychosis. And when you treat the underlying traumas, the psychosis can then go into recovery. So there's lots of different things going on here. Anxiety psychosis occurs when there's so much anxiety happening before the psychosis that the brain just switches off. It switches off its language, so you get thought disorder, like my patient Tom, they just don't make sense. And often the anxiety is replaced by a massive delusion, which sits there. And here, making the link to the causes of the anxiety is the key to the recovery. So this kind of case needs to see an expert cognitive therapists, such as our chairman today, who can deliver in-depth therapy to people with thought disorder or big delusions. So, knowing these different types of schizophrenia spectrum can help us work out what that recovery trigger might be. Without knowing these things, we're kind of in the dark, aren't we? We're faced with the immensity of psychosis without really getting a feel for what it is. Now, there is an opportunity in the first 2 years after a psychosis has started, not only for recovery, but also for remission. And that this is very exciting work that was done in Norway. I'm not sure if San Francisco has early intervention and psychosis teams. I would have thought you must have, but maybe someone can tell me later. So the minute that, or as quickly as possible, that a young person presents with voices, poor self-care, the emergence of delusions, there's a psychiatrist and a nurse there quickly. They're going to assess very quickly, and they're going to plug in all the help that's needed: family therapy, cognitive behavioral therapy, the right medicine. It's going to happen right at the front end of the psychosis. Now, this was happening in Oslo in Norway, and they followed their people up that they treated with early intervention, and 55% of the young people with a diagnosis of schizophrenia were in recovery or remission, but in actual fact, 45% were in remission. They were back to their old selves. So it seems like getting the intervention in early is very important. Now, that's not going to be helpful for your loved ones who have moved beyond that 2-year window, but for the future, we need to ensure that early intervention teams are available. It looks though that these people in Norway have stayed in recovery after 4 years because 90% of them were still on medicine, but low dose medicine, but they were still taking their antipsychotics. So that was a bit of their recovery. People who are naturally resilient tended to do better. What were the negative predictors? Pessimism, stigma, lack of available therapy, and the social aspects, lack of work placements. But we know that there's a 15% late recovery, and we know that there is recovery in the medium term. So surely recovery at some point in a person's psychosis history is to be expected. And I know that the client that Bob took into recovery after 2 years of therapy, it was very much a late recovery. So we should never despair that recovery isn't possible. So another thing is the questionnaire of personal recovery. We call this the QPR, and it's now a major outcome measure in our research trials. Service users have said to us, you don't know, you psychiatrists, you don't know what recovery is. So we said, okay, tell us. Design a questionnaire and tell us. So they did the qualitative research across a number of people who'd recovered, and they discovered what recovery was. So it was about improved confidence, improved optimism, the ability to have friendships, to feel that you're part of society, to feel that there's some purpose and meaning in your life, to have acceptance of what you've been through and what you might still have to deal with from time to time. And to feel that you've in some way got stronger, this idea of positive aspects of psychosis. So the QPR is useful. You could fill it in, thinking about your loved one, you could fill in the QPR and see where they are on the recovery trajectory, or you could fill it in together if that might seem like a good idea, or they could fill it in themselves. It could just be one of these recovery trigger moments to look at that scale and say, wow, in all honesty, I'm a long way from where I was before. I wonder if I couldn't start getting back a bit more towards where I was. These are important aspects. So things like positivity, insight, assertion, and meaning are all very important. We'll send you the questionnaire of personal recovery. Anything we talk about, Miriam's putting the slides up.
I have one.
Yes, please, Kim.
Can you define psychosis, or what are the symptoms of psychosis? Is poor self-care one of them? And then a corollary question, is psychosis sort of the definition of severe mental illness, or can it be severe without psychosis?
Yeah, it can be severe without psychosis. So if you look at a rapid cycle bipolar disorder, it's certainly very severe. And it means your mood is cycling up and down very frequently, but you've not lost touch with reality. So in psychosis, the basic definition is you've lost touch with reality. So you're hearing voices other people don't hear. You believe things other people don't believe, that is, you have delusions. You very often self-care very badly, and you very often don't make sense when you're speaking. So it is a pervasive disorder, psychosis, but recovery is possible, which is the encouraging bit of it. I can't remember what your last question was there, Kim.
I think you answered all of them.
Oh, that
You did.
miracle, then,
You
wasn't
did.
it?
Yes, you did.
And
I
Miriam,
would love to piggyback off that if I could.
sure.
I'm a clinician and I have a couple of clients actually. I'll just say one uses methamphetamine, but allegedly started experiencing paranormal experiences in her home before using meth. And this is like in her late 30s. And then I have another client who also has spiritual experiences. She believes she's also has been a meth user, but even without the meth, I'm conflicted to call somebody's spiritual experiences psychosis, because within their belief system, or it's just who am I to make a decision about that, I guess.
Yeah, I get this all the time. And people have pre-existing spiritual beliefs. They may already talk to God. Lots of people do. Lots of people have spirit guides. I can't make any comment. I don't have a spirit guide, but it can be part of your culture. Absolutely. Certainly people that are schizotypal have lots of unusual perceptual experiences. So that this certainly does happen. The other thing is that when you enter psychosis, these pre-existing beliefs and experiences can become distorted. And then when you move through the far side of psychosis, you can have further enhancement of your previous spirituality. So this is a very, very interesting subject. And I always see my clients with a very open mind to try and disentangle what is their own spiritual and cultural beliefs and what is psychotic and what I can realistically attempt to treat. And it's not an easy answer, but I think in my formulation, I need to attempt to do that. It's a great question. Okay, we're back on the presentation now. There are going to be more questions soon, I think, though. So could we have the next slide, please, Miriam?
I'm having, okay, let me go back there, sorry. Is it going forward or backwards?
It's going far too far forwards. Can you go back to where we were?
Right here.
Previous one. Right, next one.
Next one, this one, okay.
Great. So what is the opposite of recovery? And this is a state that many of our clients are in, unfortunately. And this is a state of stagnation. And stagnation is a terrible sense of social isolation. They really pretty much don't talk to anybody. They're lost within a psychotic world with low self-esteem and reduced self-nurture. It's a horrible place to be. It feels like a terrible rut that you can't escape from. There's very little pleasure or enjoyment in the rut, and you've normally lost most of your friends. Stigma pushes you further into the rut, and the terrible pessimism continues from this. This is a quote from Leonardo, which I think is quite good. Iron rusts from disuse. Water loses its purity from stagnation. Even so does inaction sap the vigor of the mind. So when we're thinking about a recovery trigger, we need to get the mind starting to work again. They need to start to work on something. And very often when I go in to see my clients, I'm asking them about old hobbies and interests, things that they might start to get their mind working on. And I was speaking recently to a man about Newcastle United, the soccer club, who have got new owners and are playing much better now. And this client with severe psychosis had been unwell for many years. And I said to him, you must remember the old days. Newcastle were a good team. I hear they're getting better again now. And he started to talk about when he used to follow the club long ago. We got his mind working again. The mind has to click into gear for recovery to have a chance. Next slide, please, Miriam. So how can we come to the point of having a recovery trigger? Well, we've mentioned the QPR. That's a real good help. My normal strategy is to find out what they used to be interested in, show an interest in it, and try and get some discussion going on that subject. I will often ask somebody that knows the client, usually a family member, what did they used to be like? What were they interested in? And go with that topic. Find out, are they doing any current projects? When did they last speak to one of their old friends? So that's the kind of way I'm always looking in my practice for an opportunity to trigger a recovery trajectory. And sometimes that can happen fairly quickly, but more often it takes time. Or sometimes I'm planting a seed which takes root and recovery happens a bit further down the line. But I think it's that this kind of interpersonal interaction is the key ingredient. I don't think there's anything more important than that. And I think families can do this at home. But again, it might take time before it starts to work. So we've got a thing down the bottom here. Are there any questions or comments? Bob, are there any questions or anything that's come through that you want to feed to me?
Yes, can you hear me okay now?
Yeah, I can hear you, Bob, yeah.
Great, yeah. So there are many good questions, a couple that have come in. One is, how do you best handle the person who's delusional, who doesn't accept or have insight into the fact that they're ill? How do you help them?
Yeah, this is a great question. It's a key question. So for me, the recovery trigger for the person who is mind is full of delusional material, it's a question. And I always say to them, what you're telling me is incredible. It's amazing what you've been through so far in your life. Can you tell me this idea that you're the second coming of Christ? How did this all start? So I want to go pre-psychotic. I think that's where I'm going to find my recovery trigger, because always in the pre-psychotic period, you discover things that have happened that make sense of why this delusion is what it is. So normally the person who believes they're Christ have had losses or have been the victim of very difficult life events. And this delusion is in some ways making sense of it all or protecting them from the extreme anxiety which they would have suffered. It's a great question.
Okay, and then one other question is about symptoms. When you say all symptoms have recovered, does that mean that the symptoms are gone? Or does that mean the symptoms are now under control?
Oh, there's another question. Well, in remission, they claim the symptoms are gone. But there's a guy called Kapoor down at the Institute of Psychiatry in London, and he said the symptoms are not gone. They have been submerged by the antipsychotic medication. And he said the minute you would remove that medication, they are just going to come back again. And if you look at relapse rates when medicine are stopped, it would seem to say that the symptoms are submerged. So Kapoor said to me, is CBT the answer here? Do you need to do something with the submerged symptoms? And with my client, Tom, that I was telling you about, who had this Phoenix-like recovery, I was trying to do the therapy on the symptoms that he had and the causes of his psychosis. So we're in quite interesting territory here. I think you almost always need the medicine and a therapy. And CBT is the one with the evidence base, but other therapies might work. Shall we press on? These are great questions.
What we'll do is there's some other questions. We could leave them until the general Q&A. We'll
Sure.
get back to them. Thank you.
Yeah. Okay, Miriam, can I have the next slide, please? Okay, so I want to talk briefly about medication and recovery. Now, this is an interesting subject. Lucht, who is the best meta-analyzer of them all, basically, he said that just over 40% of people with a schizophrenia spectrum will go into recovery with their first or second antipsychotic or clozapine. Now, clozapine is just different. It works in a different way. It works on different receptors. So you want to try 2 antipsychotics, give them a decent trial, and then quickly move to clozapine, because that first couple of years, you've got a window. The trial of clozapine should not be delayed. We've got people here in the UK who've been 10 years without a trial of clozapine. They might have gone into recovery. So these medicines in 40% can trigger a recovery trajectory. But like my patient Tom, they need to do the therapy as well. Now, there is a placebo response in severe mental disorder, which is interesting. So any treatment that the client believes is going to work can have an effect on improving symptoms. It is said that the medicine needs to keep going for at least 2 years before a gradual reduction. So what I'm always saying to people is the medicine has definitely helped. We're going to stay on it now for the 2 years, but if you decide to stop, come back to me straight away. I'll give you an appointment very, very quickly so we can discuss how to stop. Because if you stop a dopamine blocker suddenly, or clozapine that blocks just about every receptor in the brain, your brain will go into shock and you're almost certain to relapse. So I want a gradual reduction of the medication under supervision, and I'm going to plug in appointments with me, the psychiatrist, and appointments with their therapist, because as you come down, anxiety, paranoid thoughts, hallucinations can start to pop their heads up and might need attention. Can we do the next slide? So, families can use CBT techniques to improve medication adherence. Now, we've got a whole session on that. We're going to explain that stopping it suddenly will put your brain into shock. So let's not stop it suddenly. Tell us if you're going to reduce. And what I would normally do is convert their medicine into a liquid format and bring them down by 1 milligram per fortnight or per week. Supervise that reduction so it's nice and slow, and plug in the therapy. And the last person I did this with was a lady who was very paranoid, and she was on olanzapine. We brought her down by 1 milligram every 2 weeks. As she came down, she became anxious and she had paranoid thoughts again. And the therapist helped work on them, helped test them out, reduce the anxiety. She got off, she's stayed off, and she's stayed in full recovery now for about 10 years. So coming off the medicine properly is crucial. And it's something I'm always trying to teach people with psychosis and to families. So I don't know if there's any questions of that little medicine and recovery block. Or do we want to just press on, Bob?
I think because of time here, where it's a little bit past 10, maybe we'll press on. We
Let's
can always
press on.
take those questions at the end.
Okay.
I'm sure there's questions.
Next,
Thank you.
next slide, please, Miriam. Thanks. Okay, so this is about individual therapy and recovery, and people often need individual therapy. So this was about people who were refusing medicine completely. And we wanted to know if they were just not getting medicine, would cognitive behavioral therapy work? And we were offering them a maximum of 20 sessions, and we randomized them. And at 9 months follow-up, 1/3 of the CBT group were in recovery, even without medicine. So it looks like for some people, CBT can work on its own. But in the control group who were getting nothing, no medicine, no therapy, there were 3 recoveries. I thought this is massively exciting. People can recover from psychosis even without medicine and even without therapy. It's much more common to recover with medicine and with therapy, but people can sometimes do it without either. And these people stayed in recovery. Next slide, please. So this is clozapine resistant. This is people who suffered voices and delusions and poor self-care for many years. This is the real chronic group. And we found that, again, we randomized to cognitive behavioral therapy and treatment as usual, and we got a smaller number of recoveries. So 28 out of 209 had gone into recovery. And in the control group, we also had a lot of recoveries, 14. Now, this was fascinating. And the people who had recovered in the control group had all had positive life events happen to them or social change. So even for these very chronically unwell people, recovery can be possible. And this almost ruined the trial, actually, because there were 3 patients randomized to the control group who weren't getting CBT. And at this time, a very charismatic nurse opened a new group home out at the coast here. And it was near to the beach, and there was lots to do. And there was a therapy dog was there. There was lots of walks. There was things to do. And 3 people recovered just because of that move. So social aspects of recovery are very important. I'll show you a picture of this group home that caused the recoveries later. Next one, please. Now, I want to talk a bit about something families can do here. Obviously, this is recovery from chronic schizophrenia, voices and delusions. The yellow bar is the CBT group. And as you can see, the yellow bar, between initial and outcome, they've had 20 sessions. They do really well. And at follow-up, they're still getting better. They've learned things from the CBT. They've accepted the psychosis. They've understood it. They've learned to cope with it. And a lot of them go into recovery. We designed befriending as a placebo therapy, and we thought it wasn't going to work at all. And this is a devastating result because the befriending was every bit as good as the CBT at getting people improved their symptoms and got them into recovery. And I think this happened because of the extreme social isolation of people with voices and delusions. Just someone coming round once a week for an hour, showing an interest, talking about hobbies, talking about neutral subjects, doing a bit of self-disclosure as a friend would, seemed to be very powerful. In fact, the therapists came to me one day and said, Doug, you're going to have to do this study again. The patients love the befriending. And to be honest, they find the CBT a bit hard at times. What you need to do is do the befriending first and then do the CBT. I said, well, thanks very much. But this study cost £1 million and it's underway now. So we'll maybe try and do that study next. It's still a great idea for a study. Next one, please. Now, interestingly, they had a differential effect. CBT was great for voices. It was good for some negative symptoms. Befriending seemed to draw the heat out of delusions, particularly paranoid delusions. So families who have a loved one with a paranoid delusion, befriending might be a really good way to try to trigger this recovery trajectory. Next slide, please. So this is the number of people in recovery in these 2 groups. This is 18 months, so they've finished and they're followed up. 29 out of 46 with CBT. Absolutely fantastic result. Individual therapy is important to recovery. And I remember one of my patients who recovered saying to me, you were my sane reference point. I came to see you in your clinic and I tested ideas out and you gave me feedback. You were my sane reference point. But befriending can do it. Now, what was happening in the befriending? I wanted to know, and I analysed the recordings of the befriending work, and a lot of these clients were disclosing trauma to the befriender. So they were actually saying to the befriender, I've got to tell you about the things that have happened to me in my life. There's been some bad stuff. And the befriender's like, oh, well, we're not really meant to be talking about that, but I'll listen to what you have to say. So it seemed like disclosure of trauma was quite often part of their recovery with befriending, as well as the issue of working with the paranoid delusions. Next one, please. So family approaches. People with severe mental illness usually have stopped self-caring. They're not looking after themselves. They don't go to the yoga class, that they don't do things to help themselves. And so if we as family members can demonstrate that we look after ourselves, very often the family member with the psychosis or the bipolar will be interested in that, and it might trigger them to start self-caring. So we've always said that recovery begins at home, and it begins with yourself, really. Do something to look after yourself, because it's such a stressful position to be in. Do something for your own stress. Take up yoga, take up horse riding, do some personal therapy, do something to look after yourself. And tell your loved one that you're doing that no one's mental health is perfect, and we all need to do things to look after ourselves. I've seen recoveries happen at home just with small changes of communication style. I can think about one lady who, having heard about befriending, thought, right, I'm going to befriend my son. It's a crazy idea, I know, because I mean, she was a good mum and she looked after him great, but she'd never really befriended him as such, spent having bits of time put aside where you talk to each other about old interests and share information and stuff. So she did the befriending, and her son did recover. He came out of a forensic unit, and he said to her, you changed towards me at one point, and then it puzzled me, but you were definitely different. And that really helped. So befriending is a different communication style. Family therapies act to change the communication style. Family therapy has a strong evidence base in preventing relapse and aiding recovery. Unfortunately, it's often not available. It needs to be more available. Demonstrating a good work-life balance is important. Emotional neutrality at home means cutting back on criticism, anything that might appear to be too critical, and on the other hand, not doing too much for the person. So it's keeping the gear stick in neutral. That is what allows recovery to start to build, and that's what prevents relapse. That's a very, very strong research finding. Demonstrating hope and optimism is important, but not pushing the person too hard, and trying to engage them in flow activities. So I had a patient who eventually recovered. I discovered from a family member that he'd been a great fisherman. That's what he was interested before he developed his psychosis. So I went to see him, and he was lying in his bed, and I said, well, are you interested in fishing? No, I wasn't interested. So I brought my fishing magazine in. Next time I saw him, it hadn't been opened. So I thought, I'll try a different tack. So I said to him, see, fishing, I think it's really boring. It's so cold out there and it's lonely. I would never be interested in fishing, me. And he just looked at me. And the next time I went back, he said, you're meant to be a psychiatrist. You should be telling people they should go fishing. Fishing is really relaxing. I said, oh, that's interesting. What type of fishing do you mean? Oh, he says fly fishing. Fly fishing is by far the most relaxing. And in some ways, we had a recovery trigger there. We'd got hooked here on a discussion, and he did start to read the magazine. He did start to watch fishing programs, and he went fishing. And recovery is a bit like this. It goes along really slowly, and that can go on for months. And then it starts to pick up pace, and then it can accelerate. And you might be in the second year before it starts, before you start to really look at visible. So I think it was in the second year that he actually went fishing, but he did go into recovery. Next slide, please. So practicing having the conversation, this is a bit like the LEAP training, or anyone can sign up with the Psychosis Reach program to practice how to have this conversation, showing interest about the symptoms, exploring them. Certainly, the more people speak about their voices and delusions, the better it is. Using befriending, doing a lot of listening and feeding back, asking questions of fact. How might you say there's a machine nearby which is stealing your thoughts? I wonder how that might work. But is it powered by electricity? Well, what do you think? How would something like that work? Obviously, confrontation makes things worse. Collusion makes things worse. So we're asking questions from curiosity, from wanting to find out. We're trying to reduce distress. Personal disclosure can be useful, but we want to be aware of red flags that make you concerned that there might be something risky going on. Let's move on to the next one, because I want to leave time for questions at the end. Now, group therapy can be useful. I think the mistake is to put someone in a group before they have individual. So for me, I'm always trying to encourage family intervention and individual therapy. And if someone's getting to that stage in recovery where they're starting to pick up, a group can then be very useful. So some services put people straight into group, and I must say, I don't think that's the way to go. The best groups, voices groups, work well. Coping strategy groups work well. And for those that are motivated to come off and stay off, groups around staying clean of cannabis, other drugs, alcohol can be very useful. I think groups need to be similar in terms of age. If the age range is too big, they can start to fragment. For those people who are in a different culture, going to a culturally based group is very good. And when you get people starting to look after other people in the group, this is altruism. And when altruism emerges in a group, that's a very strong sign that the person who is becoming altruistic is well into recovery. Next one, please. Okay, so we mentioned social approaches. People with psychosis are very aware of their social milieu. They might appear to be switched off from it, but they're very aware of the people and their interactions and the broader milieu outside where they live. Befrienders and befriending schemes are hugely useful, but most places don't have them. Drop-in centres can be useful. Social and cultural options, training, hobbies, volunteering. I can think of a man who recovered down at the local stables. He previously had loved horses and he went down to look after them again, and the horses seemed to help him into recovery. And supported work options. Next slide, please. This is the group home, the one that just about destroyed my study. It's up to the left in this picture here. And what it did was it took people with chronic treatment-resistant schizophrenia, voices, delusions, self-neglect, and moved them from really poor quality inner city accommodation, areas where there were gangs, there were drugs, there was nothing to do. And they moved into this top left group home here, where there was this charismatic nurse and her staff. There was the therapy dog. They could go for walks along the bay. There's all kinds of interesting things there. 3 people went there with chronic psychosis. and 3 I know are in recovery because of that social change. It's exciting that there are so many things can trigger a recovery trajectory. Next one, please. We've mentioned altruism. I'll quickly mention my friend Eleanor Longden. Eleanor had a traumatic psychosis and she heard terrible abusive voices. She was very depressed. She was cutting herself. She nearly died on a number of occasions. She herself got cognitive behavioral therapy. She worked with the trauma. She made a full recovery. She sat a psychology degree. She wanted to give something back. And she's now on our research team based in Manchester. And she's done a sensational TED talk. And this is a bit of homework I often show my clients. Eleanor Longden's story is inspiring. That's a story of recovery from the depths, the deepest depths of psychosis. Deborah Lampshire, similarly amazing story. But anyone who's able to talk about the experience of what they're being through, their bipolar or their psychosis, do a talk to people, write a blog about it. I often suggest to people to become a peer support worker. I say to them, after what you've been through, you could help others by sharing how you got through all of this. And that's a very viable approach. Let's just do 5 minutes here on my last section before we can have questions. Next one, please. Now, can I go back to the previous one? 2 back, please. That one there. No, that one there. Thanks very much. Now, recovery can lead to you to a better place than you would have been without a severe mental disorder. And I think this is really important. This really is the antidote to stigma. And of course, is why the shamans of the past went out of their way to experience a psychotic episode, because it gave them enhanced spiritual and creative abilities post-psychosis. I think we were talking about this earlier. Now, Anthony Hopkins is a great example, very famous actor, and he always was a voice hearer right back from his adolescence, and he became alcoholic, and his voices, which had been very critical of him, when he worked with them and got into a bit of recovery, he described his voices as turning golden, because his voices tried to talk him out of having a drink. He would get up in the morning and say, right, I'm going off now to buy some tequila. That was his plan. And the voice would say, no, we don't need to do that. Let's go and do something different. Let's go for a walk, or we'll go to an art gallery or something. Yeah, let's not bother with a drink today. His voices talked him out of alcoholism. Now, Anthony Hopkins has a website, and if you look at Intervoice, you'll get his story there. It's amazing. In recovery, he also discovered that he had tremendous talent in art, and he became a very good painter. Enhanced creativity can occur in the depths of psychosis. So you see people start to paint when they're actually very psychotic. And these paintings can be incredibly powerful, but very often it also comes as a later stage. We see enhanced spirituality. Now, the insula is the bit of the brain beside the temporal lobe and amygdala that is responsible for deciding what is inside your body and what is outside your body. That's its job. Now, another job the insula has is to mediate spiritual and ecstatic experiences. So if you do fMRI type scans and you see monks in states of deep meditation, the insula is the area of the brain that is being mostly activated. So this seems to be how this happens. The insula is primed for increased activity by psychosis. And once you get through the psychosis, you're ready for enhanced creativity or enhanced spirituality. This might come through in writing, poetry, or design, or like some of the clients I've told you about, that gets put into helping other people with psychosis. Next one, please. So this is an example of one of my patients who went into recovery and discovered that he could paint. And he thought back to when he was ill, and these left ones are paintings of me. And the bottom orange one is kind of slightly frightening and strange. And he painted that at a time when he was still unwell. And he said, that's what I looked like when he was ill. And I looked kind of threatening. And he said, I didn't actually know if you were real or not. But he kept coming to his appointments despite all that. And when he recovered, he painted the top one, which to me looks extremely concrete. And I said to him, why does it look like that? He said that when I recovered, you looked like a real person. You looked like a proper human being. You had a proper outline to you, and you looked a proper color. So these are paintings of his recovery. This is one of his paintings, which he was able to sell, which is an image of Marilyn Monroe, which is interesting. And he took an exhibit around the UK. Next one, please. And this is one of my other clients who recovered. And when she got through her schizoaffective disorder, which is, of course, a mixture of psychosis and bipolar, she started to produce mandalas. And now mandalas are the emblem of recovery. The mandala is the emblem of universal balance and of the transformation of suffering into joy. So it's interesting, she produced mandalas. And these interlinked mandalas, one of them is made up of angels, one of them is mostly eyes, and the other one has demons on it. So she's trying to tell us something very deep with her mandalas. They're also incredibly detailed, and she's still making them. And some of them are incredibly intricate, symbolic, and amazingly colored. So it's art at a very high level. And these two clients took their exhibit around the UK. Next one, please. And this is a client that Bob worked with, went into recovery after 1 to 2 years of regular therapy, some of it online, which is very interesting. And he started to produce these fabulous, complex designs. Next one, please. And he also, next slide, please, Miriam.
It's not moving to the next slide. Hold on.
It's stuck. The gremlins have got us. And I'm going to finish with this poem, because this is what he wrote in recovery and handed over to Bob. It's a victory for company, a breakthrough for achievement, a triumph over misery, an election for my governments, a comeback from anonymity, a major gain for accomplishment, a conquest of my histories, a profit made of enjoyment. It's a pretty interesting statement of recovery. And interestingly, it echoes some of the key elements of the questionnaire of personal recovery. Next slide, please, Miriam, if you can. So here are a couple of recovery guides that I've written. Not everything we've spoken about today is in these books, but some of it is. They're not expensive paperbacks at all. One of them was written in 2009 and the second follow-up in 2019, written for families, written about recovery, CBT-informed recovery for families with loved ones with schizophrenia and other psychoses. Next slide, please. So this is just a very brief summary. We've covered a lot of ground. And I think what I've seen at the right time, even quite small changes can sometimes trigger into recovery. So I think we should remain optimistic and hopeful and keep trying the strategies that we've described. It seems crucial that you have a quality relationship with somebody else to take recovery forward. And that person needs to be patient and knowledgeable about this process. And it doesn't need to be a mental health professional, though often a therapist is needed. But this can be a family member. Within building into social, cultural, vocational recovery, we do need the bare bones of a quality mental health service so we can access the treatments we need to help recovery. And then remembering this positive aspect at the end, enhanced positivity, creativity, and spirituality. Psychosis can be a positive experience, and many clients who have recovered don't describe the psychosis as positive, but they describe where they've got to after it as being positive.
Yeah, this is basically, first of all, a massive thank you to Dr. Turkington for being here and working with us over 5 years. This has just been fantastic. And it's just a part of a series, of course. And I hope we have a big future in terms of better dissemination, not just in Marin County, but bigger dissemination of this work, because it's so important for families. If you've enjoyed the presentation, please click on the link. And we put the link in the chat, as well as it's active on your PDF to donate to our organization. And then secondly, give us feedback. We have a very brief survey on SurveyMonkey. You can take it in 2 minutes. It helps us design our programs and support our programs, and frankly, to tell our sponsors and donors the reaction to our very best programs, like the program with Doug Turkington. So Dr. Turkington has done more, in my mind, to revolutionize the care of people with psychosis and to make it compassionate than almost anyone else. So we're very grateful. Thank you so much. And thank all of you for your great questions and participation today. We look forward to seeing you at least 5 more times. Okay.
Thank you, Bob, and thanks, Deborah. It's been great to see everybody.
Okay.
It's been tremendous for me to get these questions and all this feedback. So all the best to working with your loved ones and taking things forward.